Thank you for the introduction. We are not going to present what Milshine is already working on for a long time. We expected to have the results in terms of mortality and morbidity today, but it's hard to get. And Professor Milshine is now very regularly getting in touch with me when this will come. Now we do a promise. I think all the people here are, Professor de Koning is here, Carlijn van der Aalst is here. We do a promise that next year we probably will come up with the mortality and morbidity results.
Can we put that to a vote?
Okay, now the rationale of the ROBINSCA study, it's the calcium score is the most robust predictor for coronary events. That is already mentioned also by Anna, of course. It has a high superiority to the risk factors based paradigms. It is, it improves the medication and lifestyle adherences. There is a strongly association with stroke and congestive heart failure. And for most important, I think also, because there is also a trend in the US, we put everyone on statins and we forget about every imaging, and just when everyone has statins, because it's very cheap, we checked it, it's very cheap. So an annual treatment costs no more than $120. So that will be $250 the coming weeks, but still it's $120. And a zero score is very interesting from our perspective because it excludes fully the relevant cardiac events for the coming 10 years. Now, the aim and impact definition is that we would like to prove that we have power to study for a more than 50% reduction in morbidity and mortality of coronary heart disease between the groups. And that would have a very high impact. If you look to the EU, you would decrease in 110,000 persons annually mortality. And in the USA, it would mean 83,000 persons. So that is a quite high impact. We do it in 3 arms. So the study is already finished, of course, several years ago. And so the data are all there. And we have 3 groups with precise numbers. So all in the 14,000. And we compare usual care with the score chart and with the calcium score. You can compare the score chart with the Framingham score as is known in the US. Then the results concerning the stratification is that we find that calcium was absent, and there you see a big difference with the smoking population. So this population is not typically a smoking population, but you can see here the CVD risk factors in this population. So 20% were current smokers at baseline. And if you look to the foreign learner study, they are all smokers. So that's a big difference. And that's why you find here absence of calcium score a lot more than in foreign learner. And here it was up to 40%. And the differentiation between men and women is that women will develop calcium to the same levels in 10 years as men. So when you follow the idea of the cardiologist that your age is the same as your coronary age, then the women should live 10 years longer than the man. Yeah, surprisingly, there's not a strong predictor for the BMI. So the relation with the BMI is not that strong, but there is a relation with the waist circumference as a predictor for cardiac disease. Now here you can evaluate the downsizing of the risk. That is, I think, quite impactful. So you get a downsize in quite a substantial number of persons, as you can see here in the groups for women and for men, over the 30%. And here with the score chart, you would have an indication for preventive treatment in 54, so say 55%, and with calcium only in 24%. So that really makes a difference. And if the statin therapy was really expensive, it would have had major impact. And at the moment we started the ROBINSCA study, the statin therapy was a lot more costly than it is today. And this is a visualization of the impact. And you can see that the treatment is only indicated in a lot less persons than as we do today. But at the moment you treat them all, this is not relevant anymore. Now the recommendation for to implement the calcium score in the guidelines. So we already, as a radiological society, recommended this before, I think it was 2008 or 2009. And 10 years later, the American Heart came with the same recommendation, but vice versa. So you first do your risk score, and if it's intermediate and you don't know really if you have to treat or not, then the calcium score can help you to make a solution over there. But we are aiming vice versa. You do first the calcium score, then you get a stratification. And if you are in doubt, you can use other risk factors to make your final decision for clinical treatment. So remaining questions according to this guideline are if there is a decrease in morbidity and mortality, and that is still the key question, then the long-term impact of statin therapy if you get Alzheimer after 30 years. Now, I think that's very, very difficult to measure, but if this unknown risk is this acceptable? That answer is still not there. And in most individuals, the statin treatment will not be successful in the reduction of calcium in the coronaries. Now, if we compare to foreign learning scoring, we are, so in the ROBINSCA study, we did an ECD triggered, dedicated, fully focused acquisition on the heart. Now we do it, as nicely has been explained by Anna Walsta, in one run, non-gated. So we have to test it if that is really acceptable. And we did this in several studies. And here you can see that there is only a very low reclassification rate with the technology. So that was presented in the first presentation. And the reclassification rate is only 0.2%. So that is very, very low. And I think also on the population scale, acceptable. Then the radiation dose in foreign learning is also, so this is the mean radiation dose lower than 1 millisievert in 3,626 participants, which is, I think, very nice that we can even report it. So I'm not aware of studies where this is standardly reported, and we have this per participant now also in the in our feedback. And then here, this was not presented by Anna, of course, but that this was the same stratification that has been presented in the foreign learning cohort, and we found that 33% has significantly high cardiac heart disease risk, which is a lot higher, I think, than we would have in the ROBINSCA study. And then more than 50% would have had preventive treatment if we would have had acted accordingly. Now, this has been shown already in the first presentation. Here you see also the separation between men and women, and also the difference of 10 years, more or less, in aging of the coronaries. Now, I think it's extremely important that we could prove the reproducibility of the quantification of foreign learning in almost 500 patients. So what we did is we compared the acquisition at baseline and at 3 months. And the hypothesis is that in 3 months, you should not have an increase of the calcium score that is really measurable. And what is really striking, I think that is in the, no, I skipped that one, I think. Now, what is striking that the mean calcium score, I presented that yesterday, the mean calcium score is 132 versus 129 as a mean between baseline and follow-up 3 months later. So that is incredible. I think we had only a difference of 1 point here. There's a minimal clinical relevant downgrade of 1.4% from high to intermediate risk between the two groups. So that is very good. And not all the problems in reproducibility are a consequence of the acquisition. So here you see an example that also the AI, so we are doing the coronary calcium standardly in all participants with AI. So there's no interference of any human. And we published this also in the JACC imaging as a paper. There we proved that there is a high correlation between the AI and the manual measurement. And yeah, the misclassification, so to speak, can also be due to the AI. Because, for example, the AI will not recognize when the LED is running up very sharply and comes out of the predicted field of view, then it will not measure the calcium in that region. And there can be also, if you imagine that the right coronary artery is displacing itself per cardiac beat over 5 centimeters, so there can be a lot of motion artifacts over there, which can also be misinterpreted by the AI. So there are still, if you are interested, you can read this, and we publish this also at the Cardiac Society. And here you can evaluate that that we can also measure progression. And this is the first time that that it is done in a large cohort where we compared the baseline coronary calcium with the annual follow-up. And then we find, and you can see that here in an overall score, we see a real progression in the whole group from baseline to annual in the Eggleston score from 180 to 18 to 154. So that is a real progression over the whole group. We see it also with the volume and also with the mass score. So I think this is the only publication where progression has been measured was over a period of 3 years so far. So this is the first where we can prove that there's an overall increase of Eggleston score over 1 year. So in summary, the integration of cardiovascular screening is feasible in the lung cancer screening program with the latest technology. So that is really, yeah, mandatory that you use this dual source system for the acquisition, where the protocols has been already explained in the first presentation. The CT quality assurance is in a one-run non-ECD triggered CT dual source CT data acquisition mandatory. Rigid acquisition CT protocols are a prerequisite for radiation dose limit control in screening. So that is also important, and especially in Germany, there's a high attention for the risk of too high radiation doses. 1 out of 3 participants in the lung cancer screening were at significantly risk for cardiac heart disease, so that's quite a high number. Half of the lung screening for the lung population are candidates for preventive treatment for CHD, and 50% is at low risk. So there is probably also, and we know that already, but that is something to work on, the happy smoker without emphysema, without calcium, and without nodules. So that, thank you for your attention.